Hello friends, in this video we will cover all the topics which were asked in UPSC CMS in medicine subject and in last 5 to 6 years. So I have only covered those topics which were asked and only those points which were asked. So I have not gone into the detail of any topic. So let's start with the first topic. First topic is hypothyroidism. In hypothyroidism, it is asked that increase in iodine supply can lead to two conditions, either decrease in the thyroid function or increase. If it decreases the thyroid function, then it is known as the Wolff-Chaikoff effect, and if it increases the thyroid function, then it is called as the Jod-Bezos effect. Myxedema coma occur due to hypothyroidism, and treatment will be levothyroxine and levothyroxine. If we talk about pregnancy, in pregnancy T4 breakdown increased by the placenta, so there is increase in the T4 breakdown, so decrease in the T4 will be there, so treatment will be increase the dose of T4. If the woman is taking levothyroxine, then we have to increase the dose. Decrease in TSH, or we can say increase in T3 T4 will lead to increase in the risk of osteoporosis. So hyperthyroidism will lead to increase in the risk of osteoporosis. If these symptoms were given, such as weight gain, poor appetite, cold intolerance, tiredness, constipation, etc., then these are the feature of hypothyroidism. Diagnosis will be done by TSH, T4, anti-TPO antibody for the Hashimoto thyroiditis, and TGO antibody. If TSH increase and T3 and T4 are normal, so when TSH is given more than 10 and T3 and T4 are normal, then it is a subclinical hypothyroidism. Next topic is hyperthyroidism. In hyperthyroidism, thyrotoxic crises are added. The feature will be fever, agitation, increase in the heart rate, atrial fibrillation, etc. And treatment will be, firstly, rehydration is done, glucocorticoids are given. Iodides can be given, such as potassium iodide, sodium iodide, and Lugol's iodine. Antithyroid drug such as propylthiouracil greater than carbimazole is given, and propranolol can be given for symptomatic relief. So rehydration is done, glucocorticoid is given, iodine such as potassium iodide, sodium iodide, Lugol's iodine, and then antithyroid antibodies such as PTU and propranolol is given. There is no role of antibiotics, so this is one of the previous year question, that no role of antibiotics are there. Feature of increase in the T3 and T4. hyperthyroidism के feature atrial fibrillation, periodic paralysis, osteoporosis, osteopenia, and weight loss, and it will also lead to pretibial myxedema. So if it is given only myxedema, then it occurs due to hypothyroidism, and if it is given pretibial myxedema, then it is due to increase in the thyroid, hyperthyroidism. Graves' ophthalmopathy. In Graves' ophthalmopathy, we have to remember that anti-TSH antibody is involved in the Graves' ophthalmopathy. So hallmark feature will be propoptosis, which can be unilateral or bilateral, or it can be symmetric or asymmetric. So these points were asked in the previous year paper, that it can be either symmetric or asymmetric, and unilateral or bilateral. Diagnosis is mainly clinical. Treatment, lubricants can be given, oral prednisolone can be given, orbital decompression syndrome. Generally symptoms increase on the withdrawal, so after the prednisolone. If we talk about pregnancy, the treatment in first trimester we will give propylthiouracil, in second and third trimester carbimazole and methimazole are given. Side effects will be aplasia cutis. So overall, if they are not given the trimester, then PTU will be the answer, because it is a safe drug. Next topic is osteoporosis. In osteoporosis, we have to remember this subcutaneous drug of osteoporosis is denosumab, and it inhibits the osteoclast. If oral drugs are given, then bisphosphonates can be there, or raloxifene can be there, which is SERM. So bisphosphonates and raloxifene can be given orally. In bisphosphonates, alendronate and zoledronate will be there. If they talk about IV, then bisphosphonates can be given IV also and oral also. Drugs that increase the osteoporosis will be phenytoin, lithium, methotrexate, etc. So phenytoin, lithium and methotrexate were given in the previous year questions. First line treatment for osteoporosis will be bisphosphonates. And before bisphosphonates, we generally give teriparatide, and teriparatide are the PTH analog. And if we give long time teriparatide or PTH analog, they may increase the risk of osteosarcoma. Next topic is arthritis. To monitor disease activity and to monitor disease damage, for monitoring the disease damage, X-ray and functional assessment is done. To monitor disease activity, pain, DAS28, ESR, CRP, joint tenderness and swelling, early morning stiffness, etc. is done. So these were asked in the previous year, that to monitor disease activity, pain, DAS22, 28, ESR, CRP and joint tenderness and swelling, and early morning stiffness is taken into the account. And to monitor disease damage, X-ray and functional assessment is done. If they give about rheumatoid arthritis, then PIP and wrist joints are involved and DIP is spared. In osteoarthritis, PIP and DIP are involved, wrist is spared and knee is also involved. If they talk about the early onset, then less than 45 years will be the early onset arthritis, not less than 55 years. Trauma history of trauma ki history will be there, and mostly a single joint is involved. So with it is a different type of osteoarthritis which is known as the early onset, less than 45 years, trauma history will be there, and generally single joint is involved. If we talk about the complication, then nerve entrapment can be there, subluxation of atlantoaxial joint will be there, and lymphoma may occur. So lymphoma here is catch. So after rheumatoid arthritis, complication can be nerve entrapment, subluxation of the atlantoaxial joint and lymphoma. Reactive arthritis. So causes of reactive arthritis can be chlamydia, Campylobacter jejuni, Shigella salmonella, Yersinia, Mycoplasma, Borrelia, etc. And clinical feature will be the trick is cubica, conjunctivitis, urethritis, balanitis, inflammation, keratoderma, blennorrhagicum and arthritis. So we have to remember cubica. Then diagnosis will be done by increase in the ESR, increase in CRP, stool culture and absence of ACPA, rheumatoid factors, ANA, etc. So there will be no antibody in the reactive arthritis. Treatment for reactive arthritis is NSAIDs, analgesics, steroids, antibiotics, DMARDs and anti-TNF alpha drugs. So DMARDs and anti-TNF alpha, which are also given in the rheumatoid arthritis, can be used here. Next topic is gout. If we talk about the old age, then upper limbs are involved, and normally lower limbs are more involved in the gout. So especially in the old age, upper limbs are involved, and mostly lower limbs are involved, in which valgus deformity will be there, hallux valgus. Next topic is asthma. So it is a we know that it is an obstructive type of disease, so decrease in FeV1 and FVC will be there, and ratio of FeV1 upon FVC will be less than 80. Increase in the residual volume, increase in FRC and total lung capacity will be there. Increase in FeV1 after bronchodilator, and it is increased by 12%, will be indicative of asthma. Drugs which increase asthma are beta blocker, aspirin and ACE inhibitors. So these are asked in the previous year that which drug increase asthma: beta blocker, aspirin and ACE inhibitors. In pathological, there are three findings: Crayola bodies, Charcot-Leyden crystals and Kurtzman spiral. So CCC, Crayola body, Charcot-Leyden crystal and Kurtzman spiral. If they ask about acute severe asthma, or it is also known as status asthmaticus, then treatment will be, we have to remember by O shit M. O means oxygen, S means salbutamol, H for hydrocortisone, T for theophylline or aminophylines are given nowadays, and last resort will be MgSO4. We generally do not use omalizumab and leukotriene inhibitors because they are slow acting, so they cannot be used in acute severe asthma, which is status asthmaticus, which is an attack of asthma for longer time. And assisted ventilation is given only if PaO2 is less than 60 and PaCO2 is greater than 45. So PaO2 less than 60, not less than 80. In previous year they have given 4 options in which less than 80 is also there, so that is not correct. And here greater than 60 is there, which is also not correct for PaCO2. So for PaO2 less than 60, PaCO2 greater than 45. If we talk about controller or prophylaxis medicines, then ICS can be given, inhaled corticosteroids, oral corticosteroids can be given, leukotrienes can be given, omalizumab can be given, and LPO inhibitors can be given such as Xileuton, but we do not give anticholinergics for the controller or prophylaxis. If we talk about the treatment, then OCS, oral corticosteroids, are used only if very severe persistent asthma is there, and severe persistent asthma is when there is daily attack plus daily night awakening is there. Daily attack plus both things are daily attack will be there and daily night awake will be there. Next topic is respiratory failure. Respiratory failure is of 4 types: 1, 2, 3, 4. In one, PaO2 decrease but PaCO2 is normal, but in second, PaO2 decrease and PaCO2 increase. So they generally ask about these points, that PaO2 decrease in second and also PaCO2 increase. Third is perioperative, maybe due to atelectasis, and fourth is due to shock with hypoperfusion. So what are the causes of type 1 respiratory failure? Type 1 respiratory failure occurs due to consolidation such as pneumonia, pulmonary edema, ARDS, and interstitial lung disease, and pulmonary embolism. So these are the these are the causes of type 1 respiratory failure. If we talk about type 2 respiratory failure, then the causes will be COPD. Central causes will be there. For O for COPD, obstructive cause. P for peripheral, such as neuromuscular chest wall disease. D for diaphragm injury, which involve Guillain-Barré syndrome, polio, myasthenia gravis, etc. And treatment will be non-invasive ventilation, oxygen, salbutamol, and IV dexamethasone. So these are the treatment for NIV. Here we can give BPAP. Next topic is COPD. In COPD they asked about the risk factor. So risk factor for COPD will be smoking, recurrent infection, coal dust exposure. But so only smoking recurrent infection and coal dust exposure. But we know that coal dust exposure generally lead to cold volcanic pneumoconiasis, but it may lead to COPD exacerbation or obstructive disease. If they talk about the staging or the staging of Gold's criteria for COPD, then it can be divided into mild, moderate, severe and very severe. So FEV1 less than greater than 80 will be in the mild, 50 to 79 will be in the moderate, 30 to 49 will be in severe, and very severe will be less than 30. Emphysema, chronic bronchitis and bronchiectasis. These are the diseases which are included in COPD. Emphysema also called as the pink puffer, and here compliance is increases, and the causes can be due to alpha-1 antitrypsin deficiency. In chronic bronchitis, also called as the blue blotters, and here read index increases. In bronchiectasis, we know that it is associated with Kartnagar syndrome, in which SBI will be there, sinusitis, bronchiectasis and inverters or situs inverters. So these are the features of Kartnagar syndrome, which is associated with the bronchiectasis. And bronchiectasis due to cystic fibrosis occur generally in the upper lobe. So this is asked once that cystic fibrosis will lead to upper lobe bronchiectasis. Next topic is restrictive lung disease. So in restrictive lung disease, we know TLC decreases and DLCO generally remain normal. So restrictive lung disease can be UIP or PIF, NSIP and COP. So in UIP or PIF, elderly is involved and male is involved. Honeycombing is there. This is a special point for this. Honeycombing is there. In NSIP, ground glass opacities are there, GGO. And steroid do not respond to UIP or PIF, and steroid respond well to NSIP. So for treatment of UIP or PIF, treatment is given pirfenidone and nintedanib. And finger clubbing is also present in UIP or PIF. This is asked in the previous year papers. Now we talk about the occupational diseases such as silicosis, anthracosis, asbestosis, farmer's lung and bagasosis. So silicosis is related with cement or the mining industry, and it is associated with TB or it mimics TB. Anthracosis is associated with coal dust, and it is also called as the coal worker pneumoconiasis and Kaplan syndrome, which include anthracosis plus rheumatoid arthritis. Asbestosis, if we talk about asbestosis, then it may lead to the lung carcinoma, most commonly adenocarcinoma, and most specific is mesothelioma. Farmer's lung. In farmer's lung, it is caused by the thermophilic actinomyces, and it is a type 3 hypersensitivity reaction, which is asked in the previous year papers. Bagasosis. Bagasosis is associated with sugarcane dust, and it is also caused by the thermophilic actinomyces. So some complication can be there for the occupational disease, such as silicosis may lead to the permanent motility and disability. So and anthracosis can lead to progressive massive fibrosis. So these are the complications of occupational disease. Next topic is diabetes. In diabetes, firstly we will talk obesity. In obesity, adenopectin decrease in obesity, and only stat which is used in obesity is the reversible inhibitor of lipase. So these 2 points were added for obesity in the previous year: adenopectin decrease, and only stat which is used for obesity is the reversible inhibitor of lipase. If we talk about the diabetic drugs, then some drugs may lead to the weight gain, such as sulfonylureas, meglitinides, thiazolidines, and insulins. But gliptins do not lead to weight gains. Hypoglycemia. Hypoglycemia also occur by the sulfonylureas, meglitide, and insulin. In meglitides, repaglinide and natiglinide will be included. If we talk about the weight loss due to the anti-diabetic drug, then it occurs due to GLP-1 agonist, metformin, SGLT2 inhibitors, pramlintide, etc. So, in GLP-1 agonist, exenatide, liraglutide, semaglutide, dulaglutide, etc. will be there. And metformin especially will lead to lactic acidosis. So these all are the complications of anti-diabetic drug, oral anti-diabetic drugs which were added in the previous year. SGLT2 inhibitor acts on the renal proximal tubules, so they generally acts on the PCT, and they will lead to inhibition of SGLT2, which will lead to decrease in the absorption of glucose and lead to increase in the glucose in urine. Now this increase in glucose in urine may lead to increased chances of bacterial growth, bacterial infection, so increased chances of UTI. DPP4 inhibitors are used, which are linagliptin, saxagliptin, and sitagliptin, out of which linagliptin can be used in the renal failure. So linagliptins are safe in renal failure. This point has heard many times in previous year. Next topic is myasthenia gravis and Lambert-Eaton syndrome. So myasthenia gravis antibody will be against act post-synaptically, and in Lambert-Eaton it will act pre-synaptically. And increase in the symptoms at the end of day will be there in myasthenia gravis, and decreased symptoms at the end of day will be there in the Lambert-Eaton. So on repetitive nerve stimulation, in myasthenia gravis there will be decremental response, and in Lambert-Eaton normal or incremental will be there. So decremental in myasthenia gravis, we have to remember this one. Diagnosis can be done by ACH receptor antibodies and anti-MuSK antibodies. Next topic is upper motor neuron and lower motor neuron palsy. So in upper motor neuron palsy, spastic paralysis will be there, and lower motor neuron there will be flaccid. Then increased tone and clonus will be there in upper, and decreased tone and clonus will be there. Increase in the deep tendon reflex in upper, and decrease in DTR in lower. Fasciculations are also present in lower. Decrease in superficial reflexes will be there in upper. Babinski sign, which is most commonly asked for upper motor neuron and lower motor neuron. So Babinski sign is present in upper motor neuron palsy, and lower motor neuron palsy Babinski sign is absent. So plantar flexion will be there in lower motor neuron, and dorsal flexion will be there in upper motor neuron. Next topic is cranial nerves. If they give vesicles in ear plus cranial nerve 7 palsy, then this will be associated with Rooster virus, and it is a Ramsay-Hunt syndrome. So vesicles or painful vesicles in ear plus cranial nerve 7 palsy, it is a feature of Ramsay-Hunt syndrome. They can give about third nerve palsy. So in third nerve palsy, 4 syndromes are there. First is Weber syndrome, in which with cranial nerve 3 palsy, contralateral hemiplegia will be there. If they give Benedict, then contralateral hyperkinesis, chorea, and tremor will be there. In Claudy syndrome, contralateral hyperkinesis, chorea, tremor will be there, plus ataxia will be there, which is a cerebellar sign. So when they give third nerve palsy plus cerebellar sign such as ataxia, then it is a Claudy syndrome. And when they give third nerve palsy plus upward gaze palsy, plus eyelid retraction is there. Whenever eyelid retraction is there, then it is a Perinode syndrome. If they give cranial nerve 6 palsy, then it can be single cranial nerve 6 palsy, which is Raymond syndrome, and contralateral hemiplegia will be there. Cranial nerve 6 and 7 palsy can occur together, which is a Millard-Gubler syndrome. So there are, in Millard 7 words are there, alphabets are there, and in Gubler 6 alphabets are there. So 6 and 7 are involved in Millard-Gubler, and contralateral hemiplegia will be there. Cranial nerve 6, 7, 8 can be involved together in the Fowey syndrome. Contralateral hemiplegia will be there, plus hemisensory disturbance will be there. If they give about cranial nerve 9, 10 and 11 palsy, then it will be lateral medullary syndrome, which most commonly occurs by vertebral artery or pica. Cranial nerve 12 palsy will be there in the medial medullary syndrome, and it occurs due to defect in the anterior spinal artery. So these all are the cranial nerve syndromes. Next topic is dementia. In dementia, most commonly it is Alzheimer's. If they talk about Alzheimer, then ApoE4 is not good for Alzheimer, and it will lead to increase in the chances of Alzheimer, and ApoE2 is good or protective. So ApoE2 is good, but ApoE4 is bad. Alzheimer can be increased in the Down syndrome patient, increase with the age, which is the strongest risk factors. This point is asked many times in the UPSC CMS PYQ, that strongest risk factor for Alzheimer is age. In Alzheimer, bodies will be there, which is composed of actin, tau proteins are there, flame cells are there, and neurofibrillary tangles are there, and also there will be amyloid. For mild cases of Alzheimer, donepezil is given, and for severe cases, memantine is given. If it is given about Lewy body dementia, in Lewy body dementia by Lewy, we have to remember that it will lead to visual disturbances. Lewy will lead to visual disturbances. Frontal lobe dementia or Pick's disease. So in frontal lobe dementia and Pick's disease, the special point is it will lead to early personality changes, and tau proteins will be there, such like Alzheimer will be there, but early personality change is the special point for frontal lobe dementia. Normal pressure hydrocephalus. Normal pressure hydrocephalus is asked many times in UPSC CMS in last 10 years, and the special point about this is Hakim's stride, which will include GUD, good. Gait ataxia will be there, or magnetic or shuffling gait is there, magnetic shuffling, or and then urinary incontinence will be there, and D for dementia will be there. So ataxia, urinary incontinence and dementia will be there. Another disease is CJKD, Creutzfeldt-Jakob disease. It is caused by prions, and the special point is myoclonus, and polyspike will be there in EEG, and in radiology we can see that cortical ribboning is there. So in MRI or CT scan, cortical ribboning is seen. Next topic is Parkinson disease, Parkinsonism. So in Parkinson's, we have to remember BTR, bradykinesia, tremor, which are generally resting tremors, and rigidity, which can be lead pipe rigidity or cogwheel rigidity. And gait disturbance is also there in Parkinson's. So the gait disturbance is either shuffling gait or fascinating gait. So it can be shuffling or fascinating gait, and late feature of Parkinsonism is that the dementia and depression will be late. Parkinson can also lead to micrographia, which is a small handwriting. If they specifically give about wide base freezing gait and all the features are same as Parkinson, then with wide base freezing gait answer will be frontal gait disorder, not Parkinson, and there will be difficult to start and turn. This is also seen in Parkinson, but wide base freezing gait is specific for frontal gait disorder. Parkinson can be associated with typical antipsychotics such as haloperidol, chlorpromazine. Atypical antipsychotics generally do not cause Parkinson's, but risperidone has the highest risk for the extrapyramidal symptoms, which will include Parkinson also. Lithium can also lead to Parkinson. MTMP can also lead to Parkinson, and metoclopramide can also lead to Parkinson. So in the cases of the Parkinson, for treatment of vomiting, we do not give metoclopramide because it will lead to increase in extrapyramidal symptoms. So here we can give, for vomiting, we can give domperidone. For treatment of Parkinson, we generally give levodopa and carbidopa. Both are given in combination so that to increase the reach of the drug to the brain and prevent peripheral breakdown of levodopa. Selegiline can be given for vomiting. Domperidone, we have already talked about it, because metoclopramide will lead to the increase in the EPS, extrapyramidal symptom, which will include Parkinson's also. Next topic is stroke. In stroke, if we talk about features, then we have to remember FAST, fast. Facial weakness will be there, arm weakness, speech disturbance, and time is very important for the stroke. If it is very short time, for few seconds, then it is a transient ischemic stroke, which generally remain for a few minutes or hours. But transient ischemic stroke attack can increase the risk of the proper stroke. So type of stroke can be hemorrhagic, ischemic, and transient ischemic stroke. And risk factor for stroke will be smoking, atrial fibrillation, and intracerebral hemorrhage. So for atrial fibrillation, to prevent the stroke, we give the drug, oral drug, warfarin. So this question is also asked many times, that oral anticoagulant can be given such as warfarin or dabigatran, but warfarin is preferred mode. Now if we suspect a stroke, then we have to do CT scan. If findings are present, then it is a hemorrhagic stroke. We have to send the person to neurosurgeon. But if findings are not there, then it suggests or suspected is ischemic stroke. So if time is less than 4.5 hours, then we have to directly start IV thrombolysis. Time is less than 4.5 hours, we will give IV thrombolysis. And IV thrombolysis is not done in the cases of when the BP is greater than 185, recent MI, GI bleed in 3 weeks, coagulopathy is there, and recent head injury is there. If BP is greater than 185, then we have to treat with the IV labetalol. If time is greater than 4.5, then we have to do CT angiography and CT perfusion. After CT angiography and perfusion, if penumbra is present, then we can do intra-arterial thrombolysis. Penumbra is that part which can be saved, but there is no penumbra and total damage is already occurred, then we do not have to treat. In greater than 24 hours, we only give aspirin. Score for stroke assessment is ABCD2 score. In ABCD2 score, A is for age greater than 60, 1 point is given. B is for BP greater than 90, 1 point is given. Clinical syndrome, C for clinical syndrome, if speech difficulty is present then 2, and without speech difficulty 1. D for duration, 10 to 59 minutes 1, greater than 59 minutes 2, and another D is for diabetes 1. If MCA greater than 1 by 3rd is involved, then it tells us about the aspect score.